Good morning, young people. That sounds way better. Are we excited for today? How was yesterday's session? We were able to digest the information because for myself, I was overloaded with information. Or does someone else feel different? Or are we in the same boat? Yeah. I hope we all have filled in the survey from yesterday based on your evaluation of how the session went yesterday. How many of us were able to do that? How many of us filled in the session survey that we received via email? Wow. We still have the link to the survey. Please do make sure to fill it in during your next break, hey? All right. My name is Samanda Silohenda Iyambo. I come from Namibia, and I am the Hey Voice Fund Ambassador to Namibia. I host a podcast called Sex Talks Podcast. So you guys should definitely check it out. And I also work with various young or youth organizations as well as digital youth magazines to make sure that young people are aware of their sexual reproductive health and rights. Firstly, before we can go in today's session, we would just like to ensure that all our mobile devices are on silent. Can we please do that? Make sure that it's on silent so we can be able to start off the day. Thank you. Would also just like to welcome you to the second day of the HIV and Adolescents workshop, and we will be kicking off with session 5. We ended on session 4 yesterday, so we will start off with session 5 that is titled The Right Combination, HIV and SRHR Packages. I will be moderating this session alongside Isukanji Sikazu. I hope I'm pronouncing it right. She will be here to introduce herself before we can kick off the session. Thank you.
So today on day 2, we also have session 6, which is skills building, and Nikki will be coming up on stage after we're done to give us more information. And then we have a symposium that is supported by Viv, as you can see on the presentation there. And then session 7, reaching adolescents, the most in need. And we'll close with session 8, the next generation commodities and products. Please do remember that we do have our guided poster tours this evening, and we look forward to having you come along with us. So for those that are online, our virtual attendees, welcome, and we hope to have you interact more with us this morning. As Selma said, my name is Izukanji Sikazu, and I'm happy to be here for this session with Selma. But I know Malawi is in the house. Can we hear it from Malawi? Is Malawi in the house? I'm told they had a long, long bus trip, spent hours at the border yesterday, and finally made it here. So are they still sleeping, or is Malawi in the house? Oh, not yet. Well, we have to give them a big round of applause when they finally come in, because they really traveled several kilometers in the heat to be here with us. So Selma, over to you.
Thank you so much, Suzu. So as we speak, or we have heard yesterday, but what stood out for me from yesterday's session is the fact that young people have grown out of the box. This then also leads us into this session that speaks about the right combination. Now that young people have grown out of the box, how do we ensure that we have the right package and we have packed our suitcases accordingly? For this session, we will be joined by 2 panelists or presenters that then will be speaking to us about various topics, with the first one being highlighting, or it will be done virtually, that speaks on integrating oral and mental health with HIV and SRHR care for adolescents in Nigeria. The session will be presented virtually by Morenike Oluwatoyin Folayan from the Obafemi Awolowo university in Nigeria. Do we have anyone from Nigeria? Do we have Nigeria in the house? Can we hear from Nigeria in the house? All right, since the presentation will be done virtually, I will give a brief introduction of who the presenter is, and then we should be able to hear or see the presentation on the screen. Morenike Oluwatoyin Folayan is a professor of pediatric dentistry at the Obafemi Awolowo University, Ile in Osun State, Nigeria. She holds a master's in business administration and another in education administration and leadership. She also holds the fellowship of the West African College of Surgeons. She belongs to various professional organizations and has banked several travel scholarships and has been a beneficiary of various national and international research and project grants. Morenike has served in various capacities and multiple national and international associations, committees, and projects, and as a peer reviewer for many high-impact factors health-related journals. She is a member of multiple research groups, and she has authored and edited more than 15 books and book chapters and has over 310 journal publications. She has a history of working with the community, for the community, to enhance the voices of stigmatized and vulnerable populations. May we please have a round of applause for her. I'll then hand it over to Zuzu to introduce the second presenter who will be making it to stage because they are amongst our midst. Zuzu, over to you.
Thank you. I'd like to invite Dr. Mona Ibrahim from University of Oxford in the UK. Dr. Mona is a policy engagement advisor in the UKRI GCRF Accelerate Hub based at the University of Oxford. Dr. Mona's role is to support research uptake to build evidence-based policies and programs across the sub-Saharan region here in Africa. She has worked on a range of themes, including health system strengthening, integrated HIV care, and food security and social safety nets. Please do give Dr. Mona a round of applause, and thank you so much for being in person here.
Right, we will then have to call on the abstract presenters that will be making it to stage since they are also amongst our midst. The first abstract presenter is Lina Mwango from Zambia, and they will be presenting on depression triggers in adolescents and young women in the DREAMS program. Do we have Zambia in the house, since I didn't hear any noise when we mentioned the presenter? Can we continue the round of applause as she makes it to stage, please? Okay.
And our last abstract presenter was supposed to be Silinganisiwe Dzumbunu from South Africa, but unfortunately they couldn't make it. So this abstract will be presented by Elona Tosca from South Africa. Hello. We know South Africa is in the house, and led by Professor Linda Gale-Baker. She will be presenting on social protection as an intervention for preventing HIV risk among young people in Southern African countries. So we'll get started with our first invited speaker. Thank you.
That is a virtual presentation, so I will take my seat and we can all put our eyes on the screen to hear on the presentation. Thank you.
Good day, everyone. In the next 15 minutes, I'll be presenting about integrating oral and mental health with HIV and sexual and reproductive health care for adolescents, and I'll be focusing on Nigeria, which is where my experience comes from. I'll be using this outline. First, I'll be highlighting the importance of integrating oral health care. Then I'll be sharing our experience with respect to integrating mental, sexual, and reproductive health for adolescents. And my experience comes from Nigeria once again. I'll be talking about the nexus of HIV within this interconnectedness, and then I'll highlight our proposition for facility-based management of oral, mental, and sexual reproductive health in adolescents, and then I'll conclude. And like we all know, World Health Organization is promoting integrated healthcare delivery because this is the way to go. It has multiple advantages, one of which is the fact that it's cost effective, because through integrated oral healthcare approaches, you'll be using a common risk factor approach where you identify a risk factor, invest in eliminating this risk factor, and you should be eliminating multiple diseases. In addition, it improves access of service recipients to services and improves adherence to treatment. Of concern here is adolescents' adherence to HIV treatment. Integrated healthcare service delivery also increases patient satisfaction, but more importantly, it also improves their self-care because they also have increased and better access to health literacy. And for healthcare workers, it improves their job satisfaction. For clients, it improves the oral healthcare approach and outcomes. And oftentimes, integrated oral healthcare is promoted and delivered through the primary healthcare services. But we do know that it's possible to do it at secondary healthcare as well as tertiary healthcare level, albeit it may be difficult. We do know that there's been investment and there are multiple platforms through which maternal and childcare integration happens. And what we see now is that oral healthcare is being latched on to these existing platforms. And this is very important because it's very well known that maternal oral healthcare influences children's oral healthcare. And integration can happen for children at this level, infants, toddlers, and preschoolers. But more importantly also is that the delivery of oral healthcare on this platform can happen by any practitioner, general practitioners, pediatricians, nurses, and therapists. It doesn't have to be oral healthcare practitioners. In addition, we do know and have reported about successes when oral health promotion and education is integrated into antenatal care of pregnant women. The outcome is sought that the children are born have better outcomes in terms of their oral health. And like I did note, there are multiple models to explain this. For school-age children, oral healthcare can be integrated into school healthcare programs. And usually the school healthcare programs is focused on reducing sugar consumption with the aim of controlling caries and malnutrition. And promotion can be through integration of oral health education into school nutritional education curriculum, or integrating oral healthcare programs into school nutrition programs. One of the things we've seen is that countries where the sugar taxation is being promoted, the school programs also promote ways of reducing sugar consumption to adhere to the policies in the country. In addition, programs like the WASH, which is Water, Sanitation and Hygiene Programs promoted by WHO as well as UNICEF, improves access to oral hygiene. And Thailand is an excellent example of where this is done. What happens is that children do their breaks. As soon as they come back from break, the first asked to wash their hands, which is the hygiene practice. They take their food, improves nutrition, and then they go back to brush their teeth with fluoridated toothpaste, and that's the oral health element. And this has significantly reduced the burden of oral health diseases among school children in this country. So WASH is a platform that is also feasible, but there's very little known about how WASH is promoting oral health care. I think my team is one of those that have shown that for adolescents, WASH can push and address caries program. It's associated with caries amongst adolescents. When we look at cancer prevention also, cancer has common risk factors with oral cancers. Other cancers have common risk factors with oral cancer, tobacco and alcohol particularly. And what we see being done is that in oral health care clinics, competencies are being built amongst dentists to improve their ability to provide tobacco cessation counseling. And the focus is also adolescents, because tobacco and alcohol consumption that starts in adolescence can affect their health along their life course. So oral health practitioners also can have the competency built to deliver other forms of programs, not just focus on oral health. When we look at integrated oral health care for adolescents, here's the problem. We don't find those models existing like we have for other age groups, adolescent, preschoolers, schoolers, elderlies, for cancer, but not for adolescents. And we do understand that this has its own peculiarities. They can't be found in one place. For example, we find adolescents in primary school, tertiary institutions, secondary health institutions. Adolescents don't readily come into health facilities. You have school-based adolescents, you have out of school-based adolescents. And in Nigeria, as high as 60% of school, 40 to 60% of school children can be actually out of school, depending on the region where you are. So there are peculiarities about them, but it's not impossible. We must address this. We must find a way of integrating services for them and latching on issues that are of importance to them. For adolescents, issues of importance is mental health and sexual and reproductive health. These are stigmatized services and therefore keeps adolescents out of facilities because it's stigmatized and then not getting support from healthcare providers. And so our proposition is to use a non-stigmatized platform to deliver stigmatized services. Mental, sexual and reproductive health are stigmatized, oral health is not. Okay, and in addition, you find that adolescents can readily access oral health clinics who have aesthetic issues. Also, oral health clinics are not fastidious about parental consent, which is a problem with sexual and reproductive health care access for adolescents as well as mental health care access. In Nigeria, for example, the oral mental sexual and reproductive health integration approach has been identified as a means of reaching out to adolescents, and it's in our draft National Oral Health Policy, the 2022 National Oral Health Policy, but we don't have evidence that will support the translation of this policy into practice. And therefore, my team were looking at this. And one of the things we did in 2016 is develop this conceptual framework. I'll refer you to that article published in the International Journal of Adolescent Medicine and Health, where we looked at two oral diseases, dental caries and periodontal disease, which are the most prevalent. We looked at mental health issues, anxiety, depression, and stress. We looked at predisposing factors to this mental health disorders, psychoactive substance use. A common risk factor for all the diseases is tobacco. And then we look at sexual and reproductive health problems, sexual violence. We've shown that rape is very high in Nigeria, and rape increases the risk for HIV. Sexual transmitted infections also. High prevalence of sexually transmitted infection is not treated, and it's a predisposing factor for HIV. And of course, within all this, we don't leave out the issue of peer pressure, which is important to adolescents. We don't leave out diet, and of course, the issue of personal hygiene. We then in 2021 went out to do a number of studies, and this is what our studies found. When you look at the red arrows, we didn't find a link, but when you look at the green arrows, we found a link. And some of the studies showed very clearly some links between the three. The use of psychoactive substances, for example, increased the risk for caries, and the same substance use was not associated with gingivitis. However, dental anxiety, we found was associated with moderate to severe gingivitis. We do know that dental anxiety is a form of mental health issues. When we, however, studied mental health as a concept, we did not find an association between it and caries and gingivitis. In another study, we focused on psychological distress, and we found that psychological distress as a mental health disorder was associated with increased consumption of sugar, or rather, apologies, lower consumption of sugar, but lower number of multiple sex partnering also. However, psychological distress increased engagement in risky behaviors. When we assess risky behaviors, looking at sexual reproductive health behaviors alongside oral health risky behaviors. Depression on its own was associated with higher sexual risk behaviors, showing that there's a complexity. It's not as straightforward as A is equal to B. We looked at sexual abuse and found that sexual abuse, adolescents that had a history of sexual abuse were at a higher risk of having high dental anxiety. And those that had high dental anxiety had an increased odds of alcohol intake. We do know alcohol intake also may be associated with high sexual risk behavior. We looked at suicide ideation and found that adolescents that had suicidal ideations had reduced frequency of toothbrushing and increased risk for poor oral health. Hygiene. We also found that they also had significant increase in risk for sugar consumption. However, when we looked at the gender with respect to sugar consumption, we found that actually, as female, that actually had an increased risk for sugar consumption when they had suicide ideation, and not males. Males actually had a decreased risk for sugar consumption. We also looked at practices and found out that anal, vaginal, and sexual oral sex were associated with a higher risk for moderate to severe gingivitis, though this finding was not significant, and that those that had one or more sexual partners had a higher risk for caries, though this was not significant also. We also had 4 other studies that looked at the connection between HIV as well as, sexual and reproductive health. And we found that adolescents living with HIV were more likely to report a history of sexual abuse, engagement in risky sexual behaviors, and poor knowledge of contraception. In terms of risky behaviors, we found that they were more likely to engage in transactional sex, more likely to engage in unprotected anal sex, and more likely to engage in sex with persons 10 years older, which makes it difficult to negotiate condom use. And therefore, we went on to propose this model for integrated oral healthcare service delivery for adolescents using a continuum of care. And therefore, when adolescents come into clinics, there must be systems and structures in place that can ensure they have access to care, one of which is ensuring quality and safety. Policies must support this. The clinics must provide private and confidential services and risk mitigation approaches. The care team must be trained on youth-friendly and youth competency, and they must also promote peer support. And once again, it's not just oral healthcare professionals that should be trained, but a complementary of multidisciplinary clinicians can provide the services. Finance is critical. Adolescents must have financial independence to be able to provide the services. And financial independence can be through access to health insurance that promotes independent access of adolescents to the services. When care is provided, they should have same-day appointment and not referrals, and ensure after clinic access services and online access to their care managers. And care and case management, once again, can happen at primary oral healthcare. The integrated approach can happen at primary oral healthcare level. We must also promote this access at secondary and tertiary healthcare level. And the services, once again, should be promoted through gender and cultural sensitivity, and it must focus on patient-centered care. In addition, we also did note that those dedicated hours may not be easy to approach. While we promote specific days in primary healthcare centers, we also realize in secondary and tertiary healthcare, those that 10 to 16 might be in the child clinic, and those that 17 to 19 might be in the adult clinic. And therefore, those in the adult clinic, we do ask or propose that they should have specialized access, maybe in oral medicine clinic, a special clinic where adolescents access is dedicated to, not that you make them go around all clinics. But once again, it's about building the competence of staff to deliver this integrated care. In conclusion, I would like to note that for us in Nigeria, this is a big deal because we do have a large population of adolescents. It's estimated about 30% of the population are adolescents. But in addition, we'd have a high burden of untreated oral diseases, as high as 64% of children with oral caries and after caries not treated. So it's a big issue. And adolescents also have a high risk for mental, sexual, and reproductive health problems. My team conducted a study in a semi-rural area where we found that 60% of adolescents had at least one adverse childhood experience. And we do know adverse childhood experiences increases the risk for mental, sexual, and reproductive health problems. So without designing proactively, or rather, even if it's late already in the game, but we must respond, otherwise we have a crisis, a larger crisis to deal with down the line. And this might involve us to create new platforms for actions. The old ones might not be delivering what we want. We must create new platforms. And integrating oral health care for adolescents using an oral health care platform is one of the ways we're promoting to go. These are my references. I'd like to acknowledge my team members who have worked on this, and also to say thank you for listening and the opportunity to be able to discuss this. Thank you.
Thank you so much. Thank you so much, Doctor, for that presentation. I hope that you're available online to take questions after the next presentation. And with that, I'd like to ask Dr. Mona Ibrahim to come through and talk to us about risks, rights, and multi-sectoral responses, advancing SRHR for adolescents. Round of applause to encourage her.
Thank you. Is this how we switch? Hi, everyone. I'm Mona. It's really a pleasure to be here. I'm here to talk about multi-sectoral responses for HIV prevention and to mitigate the impact of the epidemic. So I'll be kind of highlighting a range of different academic and publications across the region, mostly produced by the Accelerate Hub, which is a massive consortium led by the University of Cape Town and University of Oxford, and they like to describe themselves as academic activists. So this research will be based, will be pulled out from a range of countries across Africa, some where there's just policy partnerships and some where there's research partnerships. And of course, I stand here presenting this, but this is representing a massive range of people across the continent who've worked very hard on this. A lot of them are here today, but also watching from their own countries now. So let's start with what we've heard over the last day, over the last presentation. HIV risks come in bundles. So before I get into the presentation, I wanted to do a very quick exercise. So when you look at the structural drivers, poverty, gender inequalities, conflict displacement, stigma, and disparities in healthcare. How many people in this room are working on these five dimensions? So the structural drivers, put your hand up. Great. We move to the second circle. Gender-based violence, school dropout, food insecurity, transactional sex, poor mental health, and early sexual debut. Put your hand up. Great, some recurring hands already, that's a good sign. And finally, mortality and morbidity, HIV transmission, ART access, and intergenerational impacts. So your hands have pretty much made my point for me. We do need to interrupt these cycles at multiple levels. So global programming must mirror what this room is doing right here. We also know that there is a multiplier effect. So a risk, when combined, becomes duplicated. So when we look at hunger, inequitable relationships, individually, they do increase risk of HIV transmission, but when we look at the combination of a lot of risk factors, that number shoots up. So what can we do? And this is where the concept of accelerator comes in. So accelerators are defined as interventions that affect multiple SDGs at the same time. And as we know, SDGs are already naturally connected. So you can't have food security without good wash and electrification. You can't have good health with a polluted environment. And similarly, you can't end HIV without addressing its discriminatory drivers. So a lot of this research focuses on shifting away from looking at one lens. So when we look at a youth-friendly health clinic, are we just seeing health uptake, one outcome? Or are we seeing a range of benefits across multiple outcomes? So are we seeing increased ART uptake, retention, better health conditions, so wider than HIV? So in reality, what we're seeing is a spectrum of impacts to an intervention that affects multiple SDGs. And just to distill it, this is the one example from South Africa. When we look at the combination of parenting, safe schools, and cash transfers, so improving educational outcomes, economic outcomes, and family-based support, we do see a range of benefits for HIV and beyond, looking at good mental health, a better school progression, less rates of violence, so that it really does hit these multiple spectrum of impacts. When we then build on to look at kind of the effects food security has on highly disadvantaged populations, so adolescent mothers living with HIV, we do see kind of a range of violence reductions as well. And this is some of the work my colleague William Rudgard has led. And these are also some findings from Zambia. Quick shout out to Zambia, where we can see that there are pro-disability impacts when we use multiple packages. So a combination of cash transfers, lifelong learning, and mobile phone access does improve poverty, but there's kind of disaggregated impacts across people living with disabilities and people who aren't. In Kenya, similarly, a combination of food security, positive gender norms, and good education has improved multiple outcomes relating to adolescent pregnancy, child marriage, IPV, and sexual violence. So the general trend is that improving the economic underpinning, the economic driver of risk, in combination with other supporting programs like adolescent-friendly clinics, peer support, mental health, and aspirational support, family support, and school-based interventions, that sort of combination does seem to address multiple outcomes within HIV and beyond. We also have to think about where these layered combined programs are being delivered. So when we look at schools, these are a platform where there's almost expanding outcomes the more you layer interventions. So for example, through a school, you can deliver food and nutritional assistance, wash interventions, SRH, CSE, income generation and skills building. So we do need to find these perfect platforms to be able to deliver these packages. We also have to think about what delivery looks like in fragile settings, so in areas with conflict, with climate shocks, where in Sierra Leone, for example, a combination of microfinance and sexual and reproductive health did have these wider impacts across sexual outcomes, but also towards education. And this leads me to the next big challenge. How can our programming, how can these combined programs build resilience, or how can they contribute to helping people going through shocks? And this is where kind of the triple nexus, so looking at what programs can help to mitigate humanitarian impacts, to support development programs, and to build peace as well. And I don't have an answer for this, but I'm hoping one of you do. This is hopefully, I would love to hear more about this over the coming few sessions. And finally, we do have a lot of this documented. You're very likely to find a brief on your own countries. So please do scan this link and see if you can find what accelerators exist in your countries. Thank you.
Right, that brings us to the end of the first two presentations for today. I hope we all were able to grasp a few things. This then also leads us into the Q&A session. Do we have any questions for the presenters? We have one right there, and the mics will be circulating shortly. Do we have any other question? We see one from Doctor right in the corner. Yay, we have 2 questions for the panelists. Oh, 3. Okay. Please bear with us as the mics get to you, then we should go in that order, with one being that, the second one here, and the third one there. All right, we do see your hand. You will be the fourth one. Thank you so much.
And also just before we have the first question come through, if virtual attendees have any questions, please do post them in the chat. Secretariat is keeping an eye on the chat and will ask the questions on your behalf.
So thank you very much. I think 2 brilliant talks, and I'm really loving the way we're starting to think what are in the tailored suitcases that need to make the difference. My question is really to introduce, and you touched on it, particularly Mona, but I just want to introduce this as something that I think we need to be thinking about is the healthcare provider and the health system that sits there. So I absolutely agree, you've got to identify the platform, but there is a human body who has to then decide which suitcase do I pull down here and which components can I really feasibly deliver into, to this adolescent sitting in front of me, who might, and we need to introduce this as well, might be a YKP, somebody who, comes in and also needs a very specific set of interventions at a particular time. What are your recommendations about what we can be doing there? And maybe it's just a call to action that one of the pockets of research is what are we doing to build resilience in those healthcare providers and competency, because I see burnout on the horizon as we throw more and more at our healthcare providers. Thanks so much.
I think we can take another question and then we'll have the presenters respond. So, Alice, are you number 2?
May we please have a mic right here? Thank you.
Great, thank you. So my question is along the similar lines as Nicole Becker. I think, obviously integration is the gold standard of what we want, right? One healthcare provider providing a range of services, but unfortunately a lot of our systems, even our money, is very siloed. So I don't know if you could give us more insight of how we approach providing these, I guess, combinations of interventions. And maybe you could say a little bit about some of the data sets, right? Because I think some are cohorts, some are interventional. If you could say a little bit about that, because that's different, right? Yeah, that would be great. Thank you.
Can you hear me? Yes, okay. These are really good questions, and actually I found myself thinking about the healthcare provider question quite a lot. I used to be an emergency doctor in a really fragile setting, and it is really conflicting, these split-second decisions. Do you refer people to nutritional care for their urgent kind of needs, or do you refer to HIV and hope that they do kind of circle back to meeting all their needs? And I think investing in community level systems would be key here, because what normally happens is that it does come down on one person's shoulders, but if there's a cohesive community level system, then there's a better peer support system, there's a better referral kind of network. Community leaders who are often visiting these households can take up bits of the responsibilities. And we see that in Ethiopia in the health extension program, and I'm sure my colleague Ilona will be covering this as well. But normally communities know what they need. So investing more in them would allow us to manage the burden a bit more. And secondly, the funding structures question is a really good one as well. And I think some of what we've seen in areas with kind of like state collapses, like when you look at Yemen, when you look at Sudan, is that sometimes it forces multiple donors to kind of contribute to pooled funding. So multi-donor trust funds to be able to implement combined programming that kind of returns outcomes to all of them. And this is one thing that Chris Desmond, Prof. Chris Desmond in South Africa mentions quite a lot is that maybe we do need a sort of accelerator fund. Maybe we do need that kind of to break that funding structure to become more creative, more innovative, and to allow kind of ground up combinations instead of imposing interventions on communities. And one of the things that I really like about kind of the community healthcare worker model is that it does encourage that natural integration from the ground up. So communities naturally do tend to combine programming. So when a family is receiving HIV support, if the health worker noticed there's also food insecurity, that's a natural link that happens without having to talk to 5 different ministries to be able to implement it. So I don't think it's a solution, it's just an idea, but I hope it answers the question.
So Dr. Folayan is online. Maybe a quick response to the 2 questions that were posed. Maybe you can add to Dr. Ibrahim's response based on your experience in Nigeria as we get ready for question number 3 and 4.
Thank you. Yeah, thanks, Linda, for the question as well as the second question. I think for me, the response is probably what you had also suggested, that this is a new way of thinking. This is the way to go in terms of making funding efficient, but also with concern for healthcare providers without latching on too much. I think for me, my answer would be that these are research questions. Implementation research becomes very critical at this time to be able to learn how to do better or more for engaging healthcare providers without burning them out. Knowing also that for countries like my own country, access to healthcare professionals is becoming less and less in terms of number. And already there's a lot of burden on them with respect to people already traveling out of the country. And yes, I do agree that siloed monies happen even with donors, and siloed money happens even with governments funding, but they also would also have to learn how to integrate to be able to, pull funds together. I don't think it's new. I don't think the proposition is new, but how to do it in a way that gets more out of little has to be learned, and implementation of science becomes very, very important at this critical time. Thank you. Over.
All right, then we will be able to take question number 3. Can we have the hand again so we can be able to get your mic? Question. Huh? Okay. Yeah, I think we can also just add our names as we ask the questions. That would make it so much easier. Can we please have a mic for the 3rd person right there? And then I did see number 4 behind, so we can give the mic to her right at the back. Thank you so much.
Thank you.
Do we have the mic working for number 4 at the back? Maybe we can go with number 4. And the timer is going down here, so if you can really be succinct with the questions, your name, and quickly your question, and we'll be able to respond.
Thank you very much. It's not really a question, but it's an addition. My name's Miemba Kiweluka Aston from Zambian Hub. I'm going back to the first presenter where she mentioned on integrated oral health care delivery platforms. There's this point which she indicated have a dedicated clinic day for adolescents. A specific day in primary health care would be of a good advantage to the adolescents out there. If in here we would go back to our countries and see to it that our brothers and sisters who are adolescents in those schools, if a day can be set, maybe each term or every month, a day where they can have access to information about certain activities concerning their human development, it would be a plus. So if at all, from the ages of 10 to 16, the others, depending on their various health conditions, if we carry it out today and say, okay, let's go out there and advocate and see to it that our young ones, as they report for school, every month there is a day for adolescents. it would be an advantage and would see to it that people are growing with the knowledge about their health and other informations, my additions.
Thank you so much for that comment. I think that's a recommendation to take forward. Question in the back, number 4, your name and your question, please.
Thank you. My name is Hilda Essendi. My question is really related to the question on funding. So our evidence indicates, it's critical to do integrated programming, but are our donors also aligned to that line of thinking? And what do we need to do to walk the journey with the funders of our work? Do we need to do advocacy work? So it's great ideas, but if our donors always would have different strategies and goals around their funding streams, how do we need to walk this journey together with funders? Do we need to do advocacy work? Like some suggestions around what we could do as a community. Thank you.
Sorry, we didn't really get the question. It was a bit choppy. Can you repeat, please?
So the question is around, aligning our strategies, our plans for integrated programming with donor strategies as well. How do we ensure that our donors are also aligned to this frame of thinking? And how do we lobby to make sure that, as much as we are thinking integrated programming, some donors would be interested only in HIV. How do we ensure that they're also focusing on life skills, for example?
Okay. So maybe Dr. Folayan, you can take that. Her question is, how do we align our priorities here on the ground with the needs that we see with donor funding priorities? Maybe your experience from integrating oral, mental, and sexually reproductive health services. Sorry, we can't hear you.
Yeah, I think that's an excellent question. And I think, I'm sure there are quite a number of donor agencies that are there. I think many times when you pull the funds, what is of concern to them is appropriation. How do I explain that this is my phone? This is what I generated from my phone. I think, like the speakers suggested, it's an advocacy thing. They continue to hear and hear. There's evidence to show that phones have to pull, and then they start to do that. I don't think it's new. I don't think this push has been new. I think the MTG villages, the experiences of the MTG villages put it very clearly. When you pull funds to do things, you get this multiplier effect. It's just for us to start asking as a country when donors come that they put their funds together to make impact rather than bring it in silos. I think and the major funders prefer Global Fund, when they start to think and ask in that direction, maybe, because Global Fund will put malaria money separate from HIV money for tuberculosis, when they themselves also start to do this kind of things and provide the evidence of the multiplier effect, as the other speaker noted, I think we might just be going in that direction. And just to also add from the earlier question about dedicated time, I think that's an excellent contribution. A dedicated day might work for clinics, because one of the things I'm pushing is encouraging facility-based integration. Would also be, maybe a Monday or Tuesday is what we dedicate to the adolescents, because they usually move in groups. One person, they rather come in 5, 6, 8, rather than one on their own. So those kind of dedicated days and hours promotes their access, especially after school hours. Thank you very much. Over.
Just to add to what the professor mentioned, but also with the donor, kind of aligning with donor priorities. I do think in an ideal world, the donors should align with the country's priorities and not the other way around. And there is a shift towards country ownership, and I would say that we all do need to keep pushing for that to happen.
Thank you very much for the questions and to our panelists for addressing that. We will then move on to the abstract presentation, and we hereby call by Lina Mwango from Zambia to give us a presentation on depression triggers in adolescents and young women in the DREAMS program. May we please have a round of applause for her.
Thank you so much, Chair, for the introduction. I'm going to give a presentation on depression triggers in adolescent girls and young women that have enrolled in the DREAMS program. Just a bit of background here. Depression is a significant public health issue and the primary cause of disability-adjusted life years lost among the adolescents and young adults. It exerts a substantial negative impact on their well-being and as well as their functioning. Adolescent girls and young women globally face a greater burden of depression and doubled lifetime risk compared to their male counterparts. We implement the Circuits project, which is PEPFAR funded through CDC in 3 districts of Zambia, and we implemented the interpersonal group therapy among the adolescents that were enrolled in the DREAMS program to identify the triggers of depression. A cross-section analysis of the data that we have collected from October last year to March this year among the adolescents and young women aged 10 to 24 years who were diagnosed with depression. We screened the adolescents with a call to action form and then gathered baseline information on the symptoms of depression that they presented with. And then the AGYWs with depressive symptoms were further assessed using the Patient Health Questionnaire, the PHQ-9. And with the PHQ-9, we assessed the duration of the symptoms, the severity, as well as the potential triggers, deficit, as well as loneliness. I'll share the results that we have from the assessment that we did. So over 1,500 AGYWs were screened with a call to action, and about 1,300 of them aged 10 to 24 had symptoms of depression, of which 50% the trigger was as a result of changes in the lifestyle, 22% of them was as a result of grief, 13% as a result of isolation, and 9% as a result of disagreement, with 6% of them having multiple triggers. And the most triggers among the 10 to 14 years were life changes. Of course, under life changes, moving from one household or staying with other caregivers, as well as grief, which was around 31%. And among the 15 to 19-year-olds, isolation was the most trigger, with 14%, and disagreement at 6%. And the most common depression trigger among the 20 to 24 years were multiple factors that they were facing. In conclusion, vulnerable AGYWs in the DREAMS program need mental health support and care to cope with and recover from their depression. Programs that target AGYW should incorporate screening and psychotherapy treatment interventions to provide this important form of health care. I would like to acknowledge the following: the Ministry of Health, PEPFAR, CDC, University of Maryland, CIEB Zambia, Strong Mind Zambia, as well as the beneficiaries of the program. Thank you so much.
Thank you so much, Lena. So before we have our next presenter, Team Malawi, I think I saw you walking in. I was overly impressed with their journey to get here. So Team Malawi, are you in the house now? Yes, can I have you stand, please? Yeah. Thank you so much for making the journey down to attend this adolescent and HIV workshop. We really look forward to your participation and engagement. And for those that are joining us virtually, we really appreciate your attendance as well. Please keep engaged with us, post your questions, your comments, or send us some likes. We'll appreciate knowing that you're there and following the proceedings with us. So Selma, do you want to introduce our next abstract speaker?
Yes. Thank you so much. We will then have to... okay. All right. Our next speaker is... I can't say it.
Oh, she's the
Yeah. Okay, she will be presenting on behalf of Silinganisiwe from South Africa. So Let's give it up for her, please.
Thank you, everyone. I'm actually the third in row. I wasn't even first choice for Bolade, who's the first author. So I'm presenting on behalf of the authorship team on the screen. First author is Dr. Bolade Banunya, who's currently in Dakar, Senegal, and could not be here with us today. I will write down all the questions that are difficult for him, and you can find me later to answer them. But building on what Mona presented and on a lot of questions that many of us have around what can we do with existing services, and particularly in this analysis, we wanted, Bolade and the team, wanted to understand how social protection that is existing in these 6 countries may be linked to differences, hopefully reductions, in self-reported HIV behaviors amongst young people, adolescents and young people. We all know why this social protection has the potential to do this, because poverty, inequality, and the linked hunger and structural issues continue to be persistent drivers to HIV exposure and acquisition in adolescents and young people and all of our communities, and that we have different types of social protection. So every country has its own systems. In Zambia, I think you have social transfers, pensions, yeah? Do you have educational support, scholarships going to uniforms, maybe a dignity pack, and then perhaps food support? So maybe getting a package when the family is in distress or during a time of flood, or agricultural support like seeds for planting. And these are the 3 types of social protection that this analysis looked at. And the analysis is in 6 different countries. It included data from 37,317 15 to 24-year-olds, and this is the FIA data. I'm going to stumble on the acronym, and I won't try now just to save time, but those are the countries and the sample size at the top. Young people from Eswatini, Lesotho, Malawi, Namibia, Zambia, and Zimbabwe. And you can see that there are some differences by countries, but there's also similar. The data sets are nationally representative. Rural residents was similar, about 2/3 across countries. Just over half had secondary or higher education in this pooled data set. Only just under 1 out of 10 received any kind of social transfer. 4% had educational support, 6% food support, and 1 in 5, 18%, reported engaging in one of several sexual risk practices. And you'll see at the bottom there that there were some differences across countries. For example, in terms of social transfers, Zambia had a 4% cover reported by young people compared to 32% in Namibia. This is just what countries are offering. We did not control this, but it's worth knowing. This is the results. It's very complicated, so bear with me as I walk you through this. At the top, A, B, and C are the HIV-related risks that we are trying to reduce. Condomless sex, multiple sexual partnerships, and high-risk sex. And I think the high-risk sex is particularly relevant to think because it's very conservative. It's saying you didn't use a condom when you have in the context of sex with an older partner, when you had multiple sexual partners, or when you had sex with a partner that was much older than you. So it's quite conservative. Because we don't want to say that just anytime you have sex with someone 5 years older, it's just always unsafe. So in this case, it was saying you didn't use a condom in that context. And what we can see, these are the 6 countries. I'm not going to go country by country, but you can see that if it's to the left of that dotted line in the middle, that's a good thing, okay? If it's to the right, it's not a good thing, because to the left, it means that there is less of high-risk sex, less of multiple sexual partnerships, and less of condomless sex. And what you'll see is that educational support, that black square, is often to the left of the dotted line. Can you see that? Move your eye from top to bottom, sorry. And food support is not, it's not actually always making a difference. So you can see in Namibia, for example, it's linked to reduced condomless sex and high-risk sex. And social transfers, more broadly, you can see that they're making a difference in Eswatini, both for condomless sex and high-risk sex, and in Namibia and in Malawi. So, to summarize, all three types of social protection could help prevent condomless sex, and the two other high-risk practices. Educational support is protective across multiple countries for both condomless sex and high-risk sex in Zimbabwe. In Eswatini, social transfers, these are existing social transfers in the country, like pensions, were protective for condomless sex and high-risk sex, and in Namibia, food support was particularly protective. Now, Bolade is a curious demographer and has really, really good data skills, so he wanted to check, is there a difference between these changes amongst adolescent boys and adolescent girls? Sorry, adolescents and young people who are who have identified in the survey as girls and boys. And this is very binary, so I want to acknowledge that, but surveys give you a variable. So this is what the variable says. It's not what the young people feel and identify as. Just want to acknowledge that. But when we're looking at, and the group was about 50-50 in how they identified, male and female, what we see is that there's lower odds in both adolescent boys and girls when we compare those that didn't receive and to those who received social transfers, but that the difference, this is the bars to the second set of bars, the difference is bigger between the red bar for adolescent females and the blue bar. When it comes to multiple sexual partnerships, the difference is there for adolescent boys, and the change is similar for high-risk sex. Bolade also did this for education and food support, and what he noted in the pattern, I am running out of time, so I won't go one bar at a time, is that the effect actually seems to be, this difference we observe is amongst adolescent girls and young women. And you can see this because if you compare the red and the light blue bars that are next on top of female, they all have a bigger difference from each other. This is quite early analysis, and it's cross-sectional data. The FIA are really great national data sets, but they're still a one-time point. So you ask, so we don't know, but it is real data from what families received. So it highlights these three different types and the potential that they have, and particularly education and food support for adolescent girls and young women. So it's something for us to think about, but also the power of social protection platforms that exist in our countries. So in Eswatini, the social protection platform is a very specific kind. Could it be made more pro-poor? Could it be used as a stepping stone to add on some additional HIV prevention or SRHR programming? And that's where the scalability element may be very relevant. Thank you to Bolade and everyone else in the authorship team. All the errors are mine, and all the questions, I'll write them down for him. Zikama.
Presenters, we will be starting off with the questions. Please, as for our virtual attendees, we are expecting your questions and engagement from your end as well, so we look forward to receiving those, and then we can have hands as to any of the attendees that have questions for our presenters. May I please have some hands or indication of hands for the question? We have number 1. 1, 2, 3, 4, 5. Those are so many questions. Can we see, do we have any questions online? Okay, so we're going to go with the first 3 this side, and then we'll take one from there, another one from there, and we see how much time we have. Can we have some mics? Number 1, if you have a mic, please speak. Or where do we have? Okay, we'll have you for number 1 and keep going, so we save time. Thank you.
All right, thank you very much. My name is Diana from USAID Kenya. My question is to Lina, but first, thank you very much for sharing your work around mental health for adolescent girls and young women. So I think our greater challenge beyond just screening and diagnosis is access to treatment. So considering the fact that you are doing your work in a program setting, I'm interested in knowing what interventions were offered to the 1,319 girls that you diagnosed with depression. Thank you.
We can have the second question in that row again. So we just finish once and then we move this side. Thank you.
Thank you so much. I'm Cecilia Juvunga from Malawi. I work with an organization called Tovilani, but I also sit on the CCM representing young people. Yeah, so for Malawi, when it comes to the issue of depression, the prevalence among adolescents is at 20%. And for young people in general, is 30%. And in the GCC7, for Global Fund, we tried to advocate for the inclusion of the mental health support to the young people, to the adolescent girls and young women who are the main target also for the Global Fund. And fortunately, we now, through the Ministry of Health, will now have service providers for mental health, psychosocial support in healthy facilities. Yeah, so for a start, I think that's a good one for Malawi, though those people will not be allocated in all the healthy facilities. So I just wanted to mention that. When it comes to the issue of social protection, I think as Malawi, we really have a challenge. We have donors who are supporting adolescents and young women when it comes to secondary school education. But going further with the tertiary education, we indeed have a gap. As a result, men take advantage of the adolescents who want to continue with their education because they are willing to support them in exchange with sex. And because they are vulnerable, they can't even negotiate for safer sex. So I think donors also need to look into that so that those age-wide abuse who are brilliant and are willing to pursue their education further, they should also be supported. Otherwise, they are also at high risk of HIV and also unwanted and early pregnancies. Thank you.
So thank you. That was a contribution from Zambia Extension. That's what we call Malawi. Zambia Extension. So quick number 3 and 4 to the point, and then we'll get some quick responses. Thank you. Oh, there's a number 3 this way. Okay. Does anybody have a mic? You can go if you have a mic in your hand.
Yes, I.
Go ahead, please. Whoever has a mic.
I here.
Okay, go ahead.
Thank you so much. Full introduction. My name is Ishmael Bondapiri, a young person living with HIV from Malawi, and I'm also an alternate member of CCM representing PRHIV constituency. My question goes to Lina. Thank you so much for your presentation about depression triggers among adolescents. But I just also wanted to add another aspect that contributes to the depression among adolescents. Recently, we've been talking about climate change, which has also hit Africa hard. For the last 6 months, in Malawi, we were hit with Cyclone Freddy, leaving lives of adolescents and young men and young women at risk and also without hopes. So I think that is also another contributing factor making adolescents to be depressed. So I want to connect it with the commitment that Malawi as a country committed under International Conference Cooperation and Development. Malawi committed that they should include SRH services in all humanitarian settings. But we've been struggling to monitor that if it is happening. All these climate change, climate change happening in Africa, they are also affecting lives of adolescents and young people. I just wanted to find out from you how we are managing to make sure that we keep on providing these services to adolescents and young people where they've been hurt with climate change and other maybe. Yes, that's my question. Thank you.
All right, so one last question and a quick one, and then we'll have some quick responses. And this one, perhaps we asked Elona. Ask Elona a question.
Good morning, everybody. My name is Petronella Mlenga Mioya, and I'm from the Zambian Hub. I would like to appreciate the presentation. So what stood out for me first was the 52% of young girls that were triggered due to life changes. So looking at their counterparts who are living with HIV, now my interest is life-changing, they were triggered because of life-changing lifestyles. So for me, the question is, what then can we do for their counterparts who are living with HIV? Because from my understanding, I don't think those were necessarily a research for young girls and young women that are living with HIV. So specifically, what are some of the interventions that can be put in place for young girls that are living with HIV, and looking at how this could be also an underlining factor for them because they are living with HIV. Thank you.
All right, so maybe we can have some quick responses from Lena before we have another round of questions. And we do have time, Karen, right? We break at 10:15, so we can add a few more minutes to that. Thank you.
Yeah, thank you. Thank you so much for the brilliant questions. I'll start with our first question on what intervention we offered. So for this conference, we have actually two abstracts. One of them is looking at the triggers, and the other one is looking at how we managed the girls that had depression. So like I mentioned, the method that we used were the interpersonal group therapy, where we recruited girls of the same age, trained them in carrying out the IPTG, and they were having sessions for a period of up to 6 weeks with the girls that had depression. It's like it was a peer-to-peer approach, and from the 1,500 AGYWs at the end of the IPTG model, 92% of them were depression-free. We had a few, about 8% that didn't improve, and we work with the health facilities where we have trained mental health providers in adolescent health friendly services. So the girls that had depression after the IPTG were linked to the mental health service providers at the health facilities. The next question was on how are we managing a depression? I think I've covered it in this response. And then also triggers due to life change. So you may be aware some of the AGYWs that are part of the 1,500, some of them are living with HIV. So we don't exclude them from the DREAMS program, even as we discover during them accessing DREAMS services and we find that they are HIV positive, we still keep them. So, and some of them are living with disabilities, and that's where we have, if we didn't know, that's where we have a lot of depression. The AGYWs living with disabilities are being locked up by the families because it's associated with some form of stigma. It's a shame to have a child that has a disability. So because of the loneliness and the isolation, we found that some of these girls had depression because of that trigger of being denied social interaction. Thank you.
And we were reminded about climate change as being a potential trigger, so definitely need to keep that on the radar and put in interventions to address other life triggers that you may not have picked up. So next round of questions from here, maybe we'll start from the back. Number 2 has a mic. Go ahead.
Good morning. My name is Lisa and I work for Grassroots Soccer. The microphone is not well. Okay. This is a comment and it still goes to Lina. Thank you for the beautiful presentation. And mine, I just wanted to say that I think my take when it comes to adolescent population, as much as we need to screen and to ensure the psychotherapy treatment, I think we need to focus also much on the preventive and promotive mental health programs and intervention for this population, to be able to, equip them with both knowledge and skills, not only on the mental health, but be positive and negative, but also just to build their resilience, their coping skills, for them to be able to identify these triggers and, know how to deal with them, and just to magnify their strengths, and to, to be able to equip them with these skills, before they even go into that level where they need treatment. And I just want to say that as Grassroots Soccer, we actually have a curriculum and a program intervention called Mind Skills that really focuses more on the preventive and promotive. Thank you.
All right, thank you for that comment and recommendation. Number 1.
Okay, thanks very much. My question goes to Madam Lina. So, in your presentation, I heard you say women are more vulnerable than boys. So, in your programs, do you have any program that support a boy child? Because in our community where we're coming from, we see a lot of boys involving themselves in drug and substance abuse due to depression.
All right, we are going to take the 2 hands here and right at the front, and we will be able to wrap it up. Oh, somebody has a mic. Shoot while the mic is coming this side. Yes, those 2 hands here. Yes, you can begin with your question. Thank you.
Good morning. My name is Felix Sowa Jr. from Yuna, Zambia. My question goes to Lina. Thank you very much for that great presentation. US depression triggers, and I am a medical student, and we are project mental health that is specifically targeting students. I'm in Zambia now. We've had committed suicide. So I wanted to find out if at all in your I wanted to find out if in your programs there are any interventions or inclusion of targeting students as well in higher institutions, because I believe this is where majority of the young people are, and I think mental health in these institutions is now a pandemic. So I wanted to find out if there are any interventions that you are doing in those regards. Thank you.
Thank you so much for the questions. We are unfortunately out of time, so we encourage you to please ask your questions during the engagements throughout the course of the rest of the day, and tomorrow we will give over to our panelists to answer the questions, then we can be able to close off for the session. Thank you.
Thank you so much, and it's just exciting to see how a lot of questions around mental health. I think it's one of the neglected. It's actually a non-communicable disease that is neglected, and I think to the organizers of this conference, the next conference, I think we need to focus on mental health. We have a lot of issues and things that we have taken to be triggers that cannot even bring up depression. So thank you so much, Grassroots Soccer. We're also working on identifying and promoting mental well-being in the communities through the community sensitization activities, and that's how come we are screening and identifying the girls that may have some symptoms of depression. In terms of any programs that are supporting boys, and I heard a cheer from the young men, adolescent boys and young men. Yes, we do have interventions that are targeting the boys as well. So DREAMS is not just the girls, but we're also reaching out to the partners of the AGYWs, and these are just also the boys of the same age or the older men that do have relationships with the girls. So we are implementing the coaching boys into men, the gender mainstreaming in the community, and under our project, working with various key stakeholders, we're also doing substance use disorders. And as you know, Zambia, in the recent past, we've seen an increase in substance use, and there are so many disorders as a result of substance use. So yes, we are doing something around that. We're also doing the screening for alcohol abuse using the cage, and these mainly, it's not just the girls, but also their partners are suffering from that. Depression triggers, we're working with the higher institutions of learning. We do have a memorandum of understanding with the Ministry of General Education, where the higher institutions of learning are falling, and our target group age band goes up to 24 years. So we are also working in schools in the various communities where we're implementing. And also part of diversional therapy for the girls that have depression, we're also providing economic empowerment, where we'll pay for them to take up vocational skills training, like pay for them to do catering or do short courses in psychosocial counseling, as a way of really sustaining the girls after they have been depression-free. Thank you so much for all the excellent questions. We can continue talking. I've seen Zuzu, the young people here, feel left out. They really had quite a lot to ask, but I'm still around. We can discuss. Thank you.
So I'd like to thank all the panel members, the invited panelists, as well as the oral abstract presenters. Thank you so much. And I also want to give a big shout out to my co-presenter. She has carried the session. I was only co-opted in and I've done very little, so big up to you. Thank you so much for all the work you did to put the session together. We are going for break just now. Tea break is outside. We'll be back at 11, but before we break, I want to ask my other good friend from the organizing committee, Nikki, to come over and tell us what we're doing next.
Hi. Is it on? Yeah. So, hello everyone. My name is Nikki. I'm originally from Indonesia, but currently I'm based in Thailand. It's really good to be back as organizing committee member for this conference. This year takes place in this beautiful and peaceful Lusaka, Zambia. I promise I'll be quick. I'm currently leading the parallel skill building session, which we got 6 interesting sessions today. So at 11, it will take place at the same time at 11, right after the break, in multiple different rooms across this hotel. So in this very main room, we're gonna have Brian Zanoni, my colleague who also serves as the organizing committee members, featuring co-facilitator Alison Agyu. It's about youth involvement in HIV implementation science. So in this very main room. And then in room Mupani 1, just next to this main room, Mupani 1, once again, we got the joint UN session. It's a collaboration between UN agencies, UNAIDS, UNFPA, UNICEF, also AFRIAN and Y+ Global. It's a session designed for programmers, meaningful youth engagement in programs and HIV responses. Yep, that's Mupani 1, next to this main room. So on level 1, on the first floor of this hotel, we have the boardroom. That will take place session from Pediatric Adolescent Treatment Africa, or PATA South Africa. That's integrated services for adolescents living with HIV, ensuring self-care and optimal well-being for adolescents living with HIV. Boardroom, level 1. In the same level 1, first floor, we have the Acacia room. That would be the great team of Dr. Naim Dalal, Dr. Chikumbi, Mil, and Precious. The session titled Heart with Ears. The objective is to empower adolescents' voices, promoting innovation and collaboration, and knowledge sharing. It's to empower young individuals to actively contribute to the development of youth-friendly healthcare services, with a particular focus on HIV care. That would be on Acacia room, first floor. The 5th session, this is a youth-led session by Y+ Global, will take place in Club Lounge. It will be on a separate building, just right across this very room. The Club Lounge, separate building. It's a youth-led session, we get strong and powerful set of facilitators. We're gonna empower people to utilize social media for advocacy, including key advocacy priorities for young people in all their diversity. That will take place in the Club Lounge, separate building just across this room. Last but not least, we got the mentoring session. We call the Meet the Professors. That will take place at the lunch corner or the foyer. not far from this room. We're going to have a very intimate session where you can ask the experts on how to advance your careers as researchers, none other than Dr. Izukanji, or Zuzu, from Zambia, also Professor Lloyd, and also Professor Linda Gale Becker for Meet the Experts. That will be in the lunch area or the foyer. So we got 6 nice sessions lined up for you, and we'll see you after the break. Okay, thanks.
All right, may we have a round of applause for our panelists and abstracts as they leave. Thank you.